Hi, welcome everybody. Thanks for tuning in. My name is Ayan Ali, the Sexual and Reproductive Coercion Project Coordinator at Planned Parenthood, Ottawa. I'm joined today by Jenna Spagnoli of the Feminist Twins.
Hi.
And Amina Doreh, the Public Education Coordinator at the Sexual Assault Support Center of Ottawa.
Hello.
Today we're going to be talking about the anti-gender-based violence sector and the sexual and reproductive health sector in Ottawa, and how these two sectors can collaborate and work together to create a more cohesive community response to reproductive coercion, but also in better facilitating services, making better referrals, and minimizing barriers to services in Ottawa. So if you guys could introduce yourselves, let the audience know your background.
Sure. So this is Jenna. As Ayan said, I do Feminist Twins on the side. Right now, what I'm doing full-time is my master's in the social work program at Carleton University. And I used to work at the Women's Center at Carleton as well.
Again, I'm Amina. I am the Public Education Coordinator and Media Coordinator at the Sexual Assault Support Center of Ottawa. So SASC Ottawa, what we do, we are a feminist-based, peer support-oriented service that provides support and services to women-identified folks who've experienced sexual violence. I'm also a trained peer support worker. Prior to being a public education coordinator, I spent about 4 years, give or take, supporting women-identified folks who've experienced sexual violence. So I have kind of both expertise talking, going into the community and talking to people about sexual violence and what that pertains, but also doing the one-on-one support with the service users and survivors.
Oh, I should also mention I've been a volunteer at Planned Parenthood since 2013.
Oh, I didn't know that.
Yeah. Random tidbit.
That's cool. Yeah, so a few things that I wanted to discuss and touch on during this would be our experiences working in sexual and reproductive health and or anti-gender-based violence, our experiences specifically with facilitating access to services for marginalized communities or communities in Ottawa generally, and what that looks like in terms of like the barriers we've experienced when trying to serve communities, and also the silos between the two sectors.
Well, just from my experience, you're a collective member at SASC, right? So you've been through our training. You understand that SASC Ottawa is a particularly unique service in the fact that we're very focused heavily on the framework of anti-oppression. And that means that we have to serve the most marginalized communities and the people who are kind of being like falling through the cracks, right?
Yeah.
People who wouldn't particularly directly to a service. We have to, seek them out and do a lot of extra work in order for them to know that we're a service that's available and viable for them, right? So some of the challenges that we've faced, right, is that oftentimes the people who are the most marginalized aren't going to just pick up the phone and make an appointment. They're not going to walk into our center, right? We have to establish those connections and relationships with those existing communities by virtue of doing like outreach work, any other work that we need to do in order to, show our presence and show that we're an available and viable option for people, right? So, it's something that I try to do as much as I can with public education. Like I try my best to always seek out places that we don't normally go as an organization, because I don't think it's really great for us to just continue to go to the same places that we go to, right? Because oftentimes when you're going to the same places, you're speaking to the same people and you're not really getting the most marginalized people to be able to hear that you're a service for them, right? So with the public education piece, which is the only part I really have control over, is to try my best to be creative in ways to get into spaces that SASC Ottawa hasn't normally gotten into, right? So part of it is just doing the legwork from an organizational perspective of like, you're going to have to make those connections, establish those relationships. It's going to be a very long-term thing, right? It's not an overnight thing. And I think the failure that's happened with a lot of organizations is that they think that going into community is kind of a one-shot deal, right? Like they don't understand that when you are trying to cater to marginalized communities, you have to go in there with a sense of sensitivity and understanding.
And rapport building. Kind of see it as a trust building.
Exactly.
Dynamic, yeah.
Because like a lot of, marginalized communities, they have had historically bad relationships or experiences with organizations of our caliber or of our network, right? So part of that is kind of breaking down the barrier of like, okay, we understand that sometimes a lot of these organizations have failed you or kind of like reestablish those oppressions, right? So like we understand that like relationship building and getting marginalized communities to access our services, we have to do more of the work in order to show them that we are an option for them. And by that, it means like taking the time to understand what they need, what they want, making relationships with the existing people who are already doing the work in the community, right? Because like I notice like a lot of organizations, they don't really make those relationships with the existing grassroots folks who are doing the work. They just kind of come in and say, well, we have this service for you, you know, like instead of saying, what are you guys already doing? How can we better facilitate that? How can we provide more options for you to continue to do what you're already doing? You know, so.
Yeah. I think one of the barriers that, and I talked about this in the reproductive justice webinar, is that a lot of organizations do have really ugly histories where they not only pushed aside, but like actively worked against the best interests of certain communities. And Planned Parenthood Ottawa does have that history coming out of eugenics and population control. And that's kind of those prevailing ideas and like theories informed the birth control movement. And, you know, Margaret Sanger was a problematic person. Like she was somebody who engaged in racist practices, even if she felt, you know, she did feel that there was such a thing as an unfit type of person that shouldn't necessarily have the same reproductive freedoms as others. And she didn't necessarily think that all people of color were unfit, but she thought things like poverty and people who needed social assistance made them unfit. So,
right. Yeah.
And obviously those are disproportionately people of color, right? So I mean, Planned Parenthood Ottawa PPO does have the same kind of barriers, or not barriers so much, but like the same kind of work to do in trying to come into these communities. And it's not enough to just be like, we have the resources, we have the knowledge base, we have the know-how. It's also about being like, what are you guys already doing and how can we facilitate that? And also how can we like support the infrastructure that you've already created for yourselves, right?
I think something else that's really, I guess, kind of unique about Planned Parenthood, like in addition to having like a shady history. And so some people wanting to access service, but not knowing if the space is safe for them. Yeah. But on the other side of that too, I think another problem that's current with Planned Parenthood is that there's a lot of misinformation about the services provided.
For sure.
Yeah.
And then you have like a lot of like, I guess, conservative religious groups that are like, oh, Planned Parenthood, they're abortion providers and they do this and they're going to tell you this. And the way that Planned Parenthood is represented isn't always the right, like, factual way. So we have like a whole bunch of issues, I think, for people wanting to access services and then being like, but what really is Planned Parenthood?
Yeah, and there's also like misinformation about what Planned Parenthood would look like in Canada, right? Or like in Ottawa specifically. Like people think that we provide abortion here and we don't. We provide options and education, but we work closely with abortion providers and other sexual and reproductive health practitioners and centers.
Yeah, no, I agree, right? Like part of going into communities is also trying to alleviate the stigma of that historical, rift between certain organizations and their community, right? Like it's about establishing, like I said, the rapport, establishing the understanding and the sensitivity, but also taking responsibility and accountability for the fact that, hey, we understand that you've tried to access these particular services and it hasn't gone that well for you. But, now we're trying to work better in order to accommodate you, right? With Sask Ottawa, we don't necessarily have the same kind of history as Planned Parenthood in any capacity, right? But, we're always working to be better and do better in terms of making our services more inclusive, right? It's in the very fabric of the work that we do, right? As someone who's taken our training, you understand that it's not like a one-off thing. Anti-oppression, understanding marginalized communities, it's kind of weaved into the fabric and the ethos of everything that we do, right? So we, as somebody who represents the organization on a large scale, I try my best always, all the time, to let people know that that's our MO. That's what we do, and that's what we need. That's what we need to convey to the public, right? And again, like no organization is perfect, right? And we're always striving to do better and be better and to be more inclusive and to let people know that we are an option for them. But again, like it's also understanding, like, you know, Planned Parenthood. There are many different Planned Parenthoods all across North America. There's only, you know, one Sask, Ottawa, right? There's other, you know, sexual assault centers present, of course, but like specifically for Sask, we have our own kind of lens that's sometimes a little bit different than other sexual assault centers. So we try our best to like really preserve that and really get people to understand that we're an option for them.
So just to switch gears, we talked about barriers to these spaces that we've created for certain communities, but can we like kind of get into barriers that are created by like the silos between the anti-gender-based violence and sexual and reproductive health sectors, like the fact that we work independently of each other, and that kind of creates a pattern of ineffective referrals, no one really knowing what anyone else does or what services are still being funded or what languages they're in, what buildings are accessible.
Like, are you talking about just the gaps between communication between organizations?
Kind of. Yeah. But like between these two sectors in particular, the silos kind of create it so that we also create knowledge independently of each other, right, and nobody really has access to like one another's knowledge base.
Mm-hmm. Yeah, like, I mean, I can only speak from like Sask Ottawa's perspective. Like we try our best always to create and establish those relationships with organizations so that there is that knowledge transfer and there is that back and forth, right? Again, we're not perfect. We can always do better and be better. But, you know, for us, trying to bridge the gap is by doing a lot of collaborative work, right? Like it's very rare that Sask is going into a space alone, right? Oftentimes we're with other organizations, and whenever I take the opportunity to do like a public education piece with another organization, I'm trying my best to kind of establish that foundation of communication so that they can come to me whenever needed be to, you know, access resources, to trade resources, to understand the work that we do on that level, right? As far as some of the like independent work, you know, sometimes we are working in a bubble, right? And we are working in our own worlds. And oftentimes some of the lack of communication is just due to capacity, right? Like if all of your workers or all of the people, all of your staff and stuff are very busy and at capacity trying to make sure that stuff within your center and in your organization is being met. Oftentimes, you know, bridging that gap is like extra work, right? And sometimes people or organizations don't have the capacity to do that without, you know, hiring more people to be able to be that effective communicator, right? And I noticed like your job is essentially that from Planned Parenthood, right? Is to be that middle person to kind of be the communicator between like an organization like Sask Ottawa and Planned Parenthood, right? But oftentimes there's no other organizations don't have that, right? They don't have a coordinator to be able to, you know, transfer that knowledge and information independently, right? So oftentimes it's not like a reluctance to do it. It's more so just a capacity. So.
And then something else I was going to add to, in the VAW or gender-based violence like sector, when people are helping, let's say, a woman escape violence or flee violence in like a domestic setting, usually other forms of violence are going to be prioritized. So they're going to be asking about maybe like physical, emotional violence. And so that sexual part isn't going to be really focused, might not even be included, or it's not. And in addition to that, I'm just kind of guessing or presuming really, but my feelings are that not all VAW and gender-based violence agencies are necessarily going to train their staff to look at like sexual reproductive coercion, I guess, like in their work. So that piece is being missed out.
Mm-hmm. Yeah. I mean, I am a Sask Collective member. I didn't mention that earlier. And I am at PPO in the reproductive coercion coordinator role. And it's a little bit interesting because I often reflect on how I supported service users before I had this language, right? Mm-hmm. And so I think that the ways in which a service user might present, especially in a crisis situation. Things like, so reproductive coercion for the audience is it's basically a group of behaviors in which a person limits another person's reproductive choices or freedoms. So in like a domestic abuse situation, this can be like condom manipulation, or what some people call stealthing, the removal of a condom or not using a condom without the person's consent or knowledge. It can be pregnancy pressure, which is like giving somebody social ramifications for not becoming pregnant. So like being unfaithful because your partner doesn't want to be pregnant or things like that. Or it can also be violence towards a person in order to make them continue a pregnancy to term or terminate a pregnancy. And so obviously it's usually plays out on the dynamic of a heterosexual relationship where it's a man dominant over a woman, but it can also be a woman dominant over a man. It can happen in same-sex relationships. It can also have intergenerationally with how parents or parents-in-law can exact reproductive coercion. And then that doesn't even get into like the systemic issues with reproductive coercion, which I don't really think we're going to be able to get into today. But so my previous point was, so if I had a service user who was in a crisis situation who was coming to me, it's often not reproductive coercion that they're coming to me about, right? And that's often not the language that they're going to use it. And I guess when I think about the value of the term and about teaching or creating resources for anti-VAW or anti-GBV frontline workers, I think it would just be like salience, right? Like thinking about the sexual health of a person. Sometimes somebody will come to me and the issue will be something like they're, experiencing flashbacks, or if we're in a long-term individual support term, it could be we're talking about lots of things, and those things could be long-term effects of violence. So, but if you're talking to somebody who's in a crisis situation, reproductive coercion, usually you would hear it, you would hear the behaviors, and then you would kind of collapse it in your head as like part of a greater pattern of abuse and control, right? So there have been times where I have pushed people to seek sexual health services if they're at risk. The Civic Hospital has the Sexual Assault and Partner Abuse Care Program, and also there are anonymous testing sites in Ottawa, and I have made those referrals or accompanied them to these. But I'm very interested in maybe in your view, what the value of reproductive coercion, at least as a set of behaviors and recognizing that would be for frontline workers. And what would screening look like from a frontline perspective?
I mean, again, like a lot of the, I guess, examples of reproductive coercion that you listed off fall under the umbrella of sexual violence, right? So it is imperative that, people who are doing the frontline work be knowledgeable about the fact that reproductive coercion is an important element to, continuing the aspect of sexual violence, right? So it's only support workers be able to know what to look for, right? So again, I can't really speak for other organizations, but for SASC, we are very cognizant of the fact that we try to give our collective members and our volunteers the language and the understanding of how to pick these things up. And we also have, a extensive resource list that we give to our volunteers that if they feel like something is out of the realm of the direct services that we offer, that there is an entire list of, organizations, references, referrals that we can make in order to better fit the needs of that service user, right? So that is one aspect that we do, right? We train people to know that, not everything that somebody's going to come to you in an individual session may be something that SASC Ottawa covers, but we do create those gaps by letting them know the information of the resources available in the community. As far as what we can do better or what we can obviously incorporate is to maybe go into more depth about reproductive coercion and what that could look like and how that manifests, and how sometimes people won't even use the words reproductive coercion and they'll describe their experience.
Very rarely do. I mean, I never used it.
Yeah.
Before this role, yeah.
And then like a lot of people will be describing something that you can pick up as a support worker as, okay, that sounds like reproductive coercion. And then you can obviously give them the tools and the feedback to understand what reproductive coercion is, right? Because it's all about knowledge transfer, right? Once you as a support worker understand what that is, then you can let your service user know that, and they can better inform themselves to make the decisions in their life, right? So what we can, always incorporate and do better is to expand the knowledge base of the frontline workers and how they're able to pick up on that. I don't think it's going to be a very rigid system of screening, but it's more so just expanding their knowledge base to be able to know what is the right referral for that person, or what is the right organization that can help fit their needs.
And that would be facilitated by knowledge sharing across sectors.
Right.
Yeah. One of the reproductive coercion project has a few objectives. A lot of them are not so much about education at this point in the project, because there is only a year left. So there's the two main objectives right now is creating a referral pathway for Ottawa and like an infrastructure for service providers to determine the most effective referrals, because people do fall through the cracks when they aren't given the best possible referral, right? And we do the best we can. We use what's available to us, and we go, okay, well, such and such organization does things between these hours, and they do have an interpreter on hand, and they do have a ramp, and we do what we can. But the way things are in Ottawa, and especially, I don't really know how things will continue, what with Ford, but like funding is up and down and all over the place. And it's really hard to keep track of who is at capacity and who is able to continue to do the work that they have done or in the way that they've always wanted to do it. So that's one thing we're aiming to do, to have like a more effective, structured way where you're not just flipping through a book and going kind of like a phone book, but more in like a flow chart type thing where you're like, okay, do I need a place to be francophone? Do I need them to have this service? Do I need them to be downtown? Right? There obviously will be limitations to that, just because not all, especially this will be found in the anti-GBV and violence against women. A lot of locations are not disclosed, right? So there are limitations to that, but that is something that we're really looking forward to putting together.
But yeah, like I'd say Sask Ottawa does a really great job of that. If you've seen our resource list,
I have it at home,
it is very, like, we break it down in terms of like what organization gives what service, what demographic do they cater to, what hours do they have. We don't just have, again, like a phone book style, right? It's like we break it down via categories so that people know exactly what they're getting into. But again, there's like what they're getting into versus what's the reality of the capacity of that organization on any given day, right? So,
but also like there are barriers for Sask, even though the referrals for Sask are as up to date as they can be, and they are exceptional in terms of what Ottawa nonprofits are able to do, right? I wasn't really holding Sask accountable in that way. I was referring to kind of a broad consensus that I've gotten from the different nonprofit workers and service providers that I've been able to engage with and collaborate in the project, right? So a lot of people are not able to do this to the level that Sask is able to, or even PPO, even though the referrals we give are limited in scope, they're effective because they are limited in scope, right? So there's that. The second objective of the project is to come up with like a best practices or a protocol for screening for reproductive coercion, or anything that involves domestic violence and how it intersects with sexual health, right? So reproductive coercion is one way that happens, but it's not the only way. So we aim to have in place by the end of the project a best practices that is trauma informed for screening for reproductive coercion. I understand in like frontline, when you're working with a service user, you're not interviewing them, right? It's more of an intake process. You infer, you intuit to an extent, depending on how experienced you are. But for medical practitioners and other sexual and reproductive health providers, there is a need or a desire for a more structured approach to screening for reproductive coercion, and also with the intent to educate service users on healthy relationships, healthy intimacy, you know, what boundaries that mean. You know, some of it might be lack of having the language for their experiences, right? And I mean, these two types of screening would serve different functions. One would be for a frontline worker, it would be like, what referrals do I make? And for a sexual and reproductive health provider, it would be like, does this person need testing? Does this person need counseling? Does this person need less obvious forms of birth control? You know, because studies have found people who experience reproductive coercion in a domestic situation often are unable to stay on longer terms of term birth control.
Okay. Yeah.
One way that we hope to establish this best practices and make sure it's trauma informed and culturally appropriate and accessible to service providers, one way that we hope to accomplish that is through an advisory council, which would be comprised of both sexual and reproductive health providers and frontline workers from the anti-VAW and GBV sectors.
When were you hoping to start that?
So hopefully it would be by the end of March and probably go through to June. There would be a couple of sessions. And if anyone listening is interested in taking part or collaborating on this project in any way, please let me know.
I think that, I guess, advisory council will kind of, you know, bridge the gap in what you're talking about in terms of the fact that all of these organizations or these sectors seem to be working parallel to each other, but there isn't that kind of bridge of communication, right? So if there was an advisory council where there's like a set setting where people can sit down and talk about the challenges in their sector versus the challenges in the other sector and how we can work together to facilitate service users to get the best care that they need, right? So
for sure, yeah. And because everyone, and it would also like facilitate knowledge sharing, right? Because we've been in silos, everyone's been producing their knowledge independently of each other, and so sometimes people are talking about the same thing, but you know, using different terms, and that would help bridge that gap as well.
Ayan, is there any nonprofits that you'd be interested in working with?
So I am interested right now from the sexual and reproductive health end. I do have a couple people in mind from the Riverside abortion team. I'm interested in somebody from health. I do have SASC in mind. I really love SASC's anti-O and trauma-informed view on things. Also, SASC's model is kind of cultivated in a very independent space, in a very self-preserving space that has served the community in a very effective way.
Yeah, like we're very grassroots, even though now that we've been around for 35 years and we've established that, you know, footing in the community. Now, obviously, we're provincially funded as well, but we still have that grassroots ethos to us, right? Like
yeah, and that is a perspective that would be like so valuable to the advisory council. But yeah, I do have a couple of people and organizations in mind. It is early on right now. We're mid-January, and I don't have all of that figured out quite yet, but it's happening. So just to segue, when we were talking earlier about barriers, we didn't really get into barriers across intersections. I did a webinar that was on the project itself because Canada has next to no quantitative data on reproductive coercion, and we had to use U.S. research, sources, because they take place in metropolitan areas. They're huge samples. They're generalizable for the most part. And I kind of cross-reference that with community research and some academic research that's been done in Canada. As of now, some notable work that's being done in Canada would be Angel Foster at the University of Ottawa has a student, Elise Fortier, who is studying reproductive coercion, specifically in young women between 16 and 25. And at the University of Quebec, at Montreal, they are doing a study which is the first of its kind in Quebec.
I just wanted to ask, is there not a lot of, I guess, statistical data about reproductive coercion with Canadian Indigenous communities that you could find? Or
Oh, you mean like systemic specifically?
Right.
It's rarely kind of framed, well, at least from what I've seen.
Okay.
But it has been framed mostly as like coercive sterilization and like and within the framework of reproductive justice and Indigenous reproductive justice, right? Which a lot of things get collapsed into, like environmental racism and things like that. I unfortunately don't have a lot of stats myself on systemic reproductive coercion with regards to Indigenous communities in Canada, but I mean, I have spoken about instances of reproductive coercion by the state.
So I guess just to clarify, like your position is talking about reproductive coercion in the context of relationships. Yeah,
for the most part.
Okay,
but the advisory council would also serve to be a space in which medical and health practitioners are able to be accountable and introspective in the ways that they might perpetuate.
Okay. But yeah, I just wanted to like ask that question about like
for sure.
Because like again with you know, the Indigenous communities in Canada, you know, like you just mentioned, forced sterilization is a huge problem.
It's a huge problem,
and,
especially
you know,
in the carceral system. Yeah. Well, another area where systemic reproductive coercion is a huge problem would be is a little more understated would be for women with disabilities or individuals with disabilities in general, right? Who are not trusted with their own reproductive choices. Usually it's an avenue where reproductive freedom is very quietly restricted, right? Or taken away. Another way would be how medical practitioners have been found to push long-term birth control options or sterilization options onto individuals who are HIV positive or people who are substance dependent or trans individuals. Yeah.
Do you think that like, I guess the link between communities that have more risk to sexual violence obviously have that correlation of a higher risk to reproductive coercion as well? So
the academic sources do support the kind of overarching pattern that the more marginalized a person is or more marginalized a community is, the more intersecting marginalizations that they're, you know, navigating, the more likely they are to experience sexual violence and reproductive coercion, both by the state and interpersonally.
Okay.
Yeah.
I think too, it would also be really hard to find accurate statistics, I'm guessing.
Oh, for sure.
Because I feel like not only the state and hospitals and doctors and nurses, and you have so many people trying to hide like what they're doing.
Yep.
And we were all saying it's been happening for decades, but it would be really interesting. I don't know if there's like an expose on it on TV or if anyone is currently doing research on it, but I'm sure the numbers are much higher than we even think they are.
Oh, for sure. And also one of the barriers to finding out like just how much of an issue it is that Ottawa is so small, right? So there'll be times where you're talking to another service provider at a different organization and they will say something that shouldn't be an indicator of a specific service user, but because service users are often accessing different services and different organizations, people are recognizable off of very little information because Ottawa is so terribly small and everyone works very closely together in certain sectors. So one of the barriers to finding out how much of the issue is that we don't want to make people unsafe, right? And we don't want to create further barriers to services because someone discloses something that they experienced by a service provider. Even though that's necessary, even though we need that there, it doesn't keep people safe.
Yeah, and just like Jenna, what you were talking about, like the reality of statistics and how it doesn't usually reflect the reality of you know, survivors and people who are experiencing it, just like from the sexual violence end, right? Like the majority of people who experience sexual assault or sexual violence aren't going to the police. They aren't going to the hospital, right? So the statistics that you grab from that are usually people who've gone through that system, right? And it's not reflective of the countless other people who have not accessed those services, right? So statistics are great to understand that it is a problem and it is something that needs to be addressed, but it never usually encapsulates the entirety of the issue, right? So I understand your frustration with like, you know, trying to find statistics, especially in the context of the Canadian system to try to find stuff that can give leverage to the work that you're doing. So.
Oh, and for sure. And the needs assessment that was produced by this project by the former coordinator who did amazing work, Samuel Lugoma, she was able to produce the needs assessment because she had over 40 service providers giving their data, right? So even the information we do have is filtered through the lens and the experiences of service providers who, again, for various reasons might not be getting the full story from service users, right? So that's another limitation.
I think another thing too with getting statistics and data, especially when it comes to reproductive coercion, is that not, like we kind of talked about this before, how not everyone uses that language or knows what it is. So then it could be happening to tens of women in Ottawa or people in general, but they don't really know that they have a bad feeling about it. They don't have the words to express what's going on, or or even worse, they might not even know that they might normalize it. They might be like, oh yeah, well, my partner does this or forces me to do that or whatever. And like, it makes me upset, but I don't think it's a big deal. They do it on TV or it's in the media, and I think people get a lot of information and things get normalized through television and social media. And so if someone's watching a show and the characters are doing really awful things like that, then people are like, oh, well, that's just normal. And that's how they're getting
for sure.
Yeah.
And it kind of ties into how, like, when we were discussing providing support to a service user, and reproductive coercion might be like the least of their concerns because it's wrapped up into all of the other things that they're coping with, right? Like if they're in a crisis situation or if they're discussing something that's long term, reproductive coercion is almost an aside sometimes.
Do you consider it sometimes to be like a byproduct of the sexual violence that they're already experiencing? Like they don't see it as something that is an integral piece that they want to get help with. It's
for sure. Yeah, for sure. But, and I don't like to center, I don't like to decenter the people experiencing reproductive coercion. I wouldn't want to decenter the survivors, but it is also a public health issue, right? So children that are produced through unwanted pregnancies or pregnancies that were not intended to be carried to term are usually sickly, usually smaller in terms of birth weight. There are a lot of comorbid issues, congenital issues that, that children can develop. So it's like, I don't want to be like, what about the babies that are produced by this? They're not even healthy, but like that is an issue. It is.
You said it like it doesn't begin and end at the service
user. It doesn't begin and end.
Yeah.
It's a public health issue, and often sexual violence or all forms of violence, whether they're interpersonal or environmental or by the state, they all end up in one way or another being a public health issue.
Right.
And how do you think we could try to bring awareness, I guess, to this issue?
It starts intersectorally, right? And then it moves into public education, and it starts a more a broader cultural conversation about the ways that we make reproductive choices, and having consent culture kind of extend to that, right? So I just wanted to segue into a hopeful note. Hopefully, close us off on a hopeful note. Once we, as an Ottawa community, have established some semblance of intersectoral cohesion, a collaborative, cohesive community response to sexual violence and reproductive coercion and all of this, what could be our next steps? Like, what do we have to look forward to? Hopefully, knock on wood, once this work is in progress.
I'd like to see sexual coercion be discussed in high schools and in sex education as part of consent culture, because I feel like in order for it to be more recognized and to raise awareness, we need to reach high school students specifically.
Yeah. And condom manipulation and birth control sabotage does start quite young. As early as 15 to 16.
And I guess, like, in an ideal world, obviously sexual reproductive coercion would be like decreased, right? The fact that people have more information, people have more knowledge, we'll give them, like, we'll empower them to be able to make their own decisions and to be able to notice that they're in a situation where reproductive coercion is occurring, and then be able to, you know, make those steps to get the right services that they need, right? And it can also give them the opportunity to recognize a situation where a potentiality of reproductive coercion can exist, right? So that they are given the tools and the framework to be able to sense what's going on so that they can essentially prevent it from occurring, right? All education is giving people the tools to be able to empower themselves to make the right decisions, right? So, you know, in a perfect world, we would have a decrease of reproductive coercion by virtue of, you know, now that organizations are on the same page and are doing the work that it takes to have a cohesive network of knowledge sharing and understanding, then that will kind of trickle down to eventually service users being able to, or just people at large, right? Not somebody who's been affected yet, but can recognize the situation, not even with themselves, but with someone that they know as well. So ultimately, all of this is just trying to create a world free of reproductive coercion, but free of sexual violence as well. So,
well, I'd like to thank you guys for your time today. Thank you for joining me.
Yeah, thank you for having us. Like, I really appreciate that you reached out to us and want to get the perspective of people who work in the field of gender-based violence and sexual violence to get some insight about like what we do and like how we can better, bridge the gap. So.
Yeah, thanks, Ayan and Planned Parenthood for having me as well. I really appreciate it.
We would also like to thank our producer, Riley Evans. Thanks so much for your patience today. This took much longer than it should have. Thanks so much for listening in. Talk to you soon.